So we are talking about PCR management, a situation which most of the interior segment surgeons dread. They would rather that this should not happen, but if it happens, they should have an option to manage it so simply that the fear out of a PCR goes out. So over a time, we have developed some techniques. We have been using it regularly in our system. Dr. Alka here, working with us, now knows that we have something which is called a PCR kit. The moment there is a PCR, we open the kit and start working. So I'll take you through this process. Maybe you'll find some tips which are useful in your routine practice. And to start with, a small introduction. So the moment you notice a PCR, I'll keep the volume down. Now a PCR has happened, so the first thing you do is you fill up the chamber with viscoelastic. That is the first immediate reaction. And then you relax. And then you set up your system around the eye. So use a IV drip attached to a bottle height which is just 24 centimeters. 30 centimeters is 1 feet, 12 inches. 24 centimeters is about 10 inches, just this much. This is the bottle height that you need, so that the IOP it maintains in the eye is 18. And then you use a vitrector. Vitrector in the IA cut mode. If you have vitreous there, then cut mode first, remove the vitreous strands, then come down to the IA cut mode, where the foot paddle 1 is irrigation, foot paddle 2 is aspiration, and foot paddle 3, you can be part of our discussion. And foot paddle 3 is cutter. So here, when I am removing these cortical pieces, in foot paddle 2, it is working like an irrigation aspiration system. And the moment the cortex material is engaged, I go to foot paddle 3, and in the cut mode, I cut out the cortex along with any attached vitreous strands. So I don't have to remove the cortex, then again come into the eye, do a little cutting with the cutter, then come out, use an IA to remove the cortex, then the vitreous is disturbed, then again go in with the cutter cut. So everything is taken care of with this cutter. Once I enter the eye, I finish the cortical aspiration with any attached vitreous strands and come out. I'll show you how simple is it. So the next point is, this is the system. A normal IV stand, we are all used to keeping the IV stand at this level, bottle height of 100 or 90. Now it's very difficult to conceptualize that in this case the bottle height, not here, let it fall down to the bottom of your stand. And the height is measured from this level in the drip set to the eye. And this has to be just 10 inches, just 10 inches. Eye to here, you can hardly make out ki bas itna sa, itne mein kya hoga. This is giving you an IOP of 18, which is the physiological IOP that will keep your eye inflated at all times. Will never let the chamber collapse, will not hydrate the vitreous, and you can move in and out of the eye comfortably at all time without worrying कि मेरे को पहले visco डालना है या fluid डालना है, then I bring out my instruments. You have to forget about all that. Focus on the vitreous and the PC rent, and not these small things which you have to do simultaneously when you're handling a PC rent with vitreous. Right? So this is the scale which tells you bottle height 24 gives you an IOP of 18. And when you have a bottle height of 88, 90, which you normally have, and you don't lower your bottle height when you have a PC rent, your IOP is 65. तो naturally जब 65 होगी तो इतना pressure होगा eye के अंदर that it will churn up the vitreous. You want a physiological IOP 18 कि vitreous नीचे पड़ा है and the pressure is such in the eye that there is no vitreous disturbance throughout your surgery. Right? This is the crux of the whole management. Let us see how this works. So, the second thing, first thing is the bottle height. Hi, Dr. Rohit. Aja, upari aja. Welcome to Dr. Rohit, another prolific phacosurgeon and a lot of experience with complicated situations. So, the second thing, which is very important, the first thing was the bottle height, which has to be at 24 centimeters, that is 8 inches. And the second thing is you need an anterior chamber maintainer attached to this bottle, which is going to keep that perfusion in the eye continuously from another port. Now for this, we have devised an anterior chamber maintainer which is slightly different from all the anterior chamber maintainers which are there in the market. All the ACMs in the market are the ones which open from the tip. If you use that ACM, the fluid will go and hit the vitreous. It could churn up the vitreous. We have kept the tip blocked and the fluid comes out from the side as it comes out in a bimanual IA system. You have the tip blocked, no? The fluid is coming from the side so that the fluid is not disturbing the central area. It's just oozing from the side very softly. The central area does not have the ripples that you would expect and get disturbed by. Okay? So, no need to fill the AC with visco every time we move in and out of the eye. Maintains physiological IOP at 18, preventing or reducing vitreous hydration, swelling and further prolapse of the vitreous. Right? Now, you are ready to handle situations. One situation is you have a PCR with residual nucleus. One situation is you have a PCR without residual nucleus. So let's go one by one. Let us first say without residual nucleus and see how we are going to manage this. First situation, PCR. This was a posterior polar, a PCR. In the center, I came out just like that. Not a great idea. The vitreous had prolapsed. I have put in an ACM, and you see, whenever there is a vitreous, it will always move towards one of the ports, one of the side ports or one of the main ports. These are the only three places the vitreous strand can move. So you saw me here, I just isolated the vitreous strand, brought it to the center, and I'm using my cutter. This cutter was in the cut IA mode. Now I have gone to the IA cut mode. I'm using it like an irrigation aspiration instrument, holding the cortex, bringing it to the center. And if there's any attached vitreous strand to it, as I cut it, there's a vitreous strand attached to it, it got cut with the cutter along with the cortex. Right? So the dissection becomes so simple. See this? Hold the cortex with the cutter, it comes to the center, cut it, and I've removed half the cortex. Now the next challenge, I don't want this rhexis to run out or this tear to run out. So I'm doing what is called a posterior CCC. That means I am rounding off the edge of the tear so that it does not spread out further. For here I need three things. I need retroillumination total, I need a higher magnification and a higher light. So I've rounded off one edge, the other edge is still there which can run off to the periphery. The ACM is maintaining the chamber. You can see this little notch here. This means there is a vitreous tag here somewhere. ठीक है ना? So I tackle this tag here. You see the tag there? The tag, either you cut it with a cutter or as you detach it from this area, from the port, it just sinks back. Now there is no stretch here and I am rounding off the second part of the tear. So, second part rounded off. Now you are safe. Now this rexis is not going to run out further. Now, if you have sufficient posterior capsule, like we had in this case, you can put in a PCIOL. If not, you would have done a different IOL. Okay. So let's see this, another similar situation. ACM is there in position, IOP of 18, cutting out, holding out the cortex with the IA system with a cutter, removing it. Here, now there are strands attached to this, so I cut it out with the attached vitreous strands. The torn edges are not running out because the chamber is not too, the IOP is not too high. Now again, you see what I am doing. I've increased the magnification, increased the illumination, total retro illumination. I can identify and hold it with a 25 gauge micro rexis forceps. This is not a 23 gauge. 23 gauge will not give me so much of a flexibility through a side port which is 1 millimeter in dia, 1 millimeter size. So I need a 25 gauge micro rexis forceps so that I have some flexibility to move it in the eye. The two edges are rounded off, I am safe. Again, I could put the lens in the bag, but I wanted to demonstrate here that I am putting the lens in the sulcus. Again, no visco. This is under fluidics only. No visco, because now the visco will drop in the vitreous and cause a late rise of IOP. So I put the lens under hydro, first open it up over the iris, then dial it under the iris. So this is in the sulcus. This is what most of us normally do, right? PCR, vitreous, you do a little vitrectomy, you put a lens in the sulcus, and that's it. And then we should do what we are doing here, an optic capture. That means I've captured this edge under one side, the other side. You can see this notch here, which is showing कि यहाँ पे haptics है, इसलिए यहाँ पे capture नहीं हुआ. This area, the optics have gone behind the rexis margin. This area, the optics have gone behind the rexis margin. Now you have a continuous diaphragm of the capsule and the lens. So vitreous can never come up. So you don't need to make a peripheral iridectomy here. ठीक है ना? Continuous diaphragm and the IOL is stabilized in the center. A perfect situation. So let's take another situation. A PCR, the same steps. So it is not very difficult once you understand these steps. The same steps, use an IA system to remove the cortex, identify the rent behind. This rent is not spreading out because the IOP is controlled. Again, the same technique, side port, I am rounding off the torn edges. So it is not just a fluke. You can actually round off the torn edges so that the rexis does not run out. And then if you have sufficient posterior capsule, say 50% or more, then you can put a lens in the bag. So here I had sufficient posterior capsule. So I'm putting a a normal IOL which was designed for in the bag implantation. The same lens I'm putting in the bag. I'm not worried about it sinking. But still, it's a soft lens. It can fold and collapse at times. So I'm going to show you something very good. A reverse optic capture. So now instead of pushing the haptics back from the sulcus, I'm going to lift up the optics from the sulcus and bring it over the anterior capsule. See that? A 3-piece IOL, I'm bringing the optics over the anterior capsule. The haptics are still in the bag. And now this is very firm. You made a full capsule lens diaphragm, preventing the vitreous from coming up. You can see this here. You can't touch the anterior capsule here because it is behind the optics, but you can see this stretch area here where the haptics are in the bag, right? This can even work in larger lens. This can even work if you have a toric IOL. So this can work if you are doing a PC IOL and you don't have a backup 3-piece IOL, but your rexis is made. You can put the lens in the bag, keep it under control that it doesn't sink, and immediately pick up the optics and do a reverse optic capture. Right? If you have a toric lens and you can't have a backup for a toric lens, then what do? In a toric lens, you can use the same technique, dial it into position and lift up the optics so that you have a toric IOL single piece in position, and you have saved the situation by a reverse optic capture. So the reverse optic capture is a marvelous technique. With this, you don't need a backup 3-piece IOL if you can master it. Let's see another situation. PCR with a planned toric IOL. Now, in this, the PCR is huge. I had a planned toric IOL. The rexis is run to the periphery, full on. There is no scope of rounding off the edges. I still have a toric IOL to place. Now what do? So this is the axis where the toric IOL is to be placed. Can I still place a toric IOL here? I just told you I can put the lens in the bag and do a reverse optic capture. Let us see how this case goes. I'm trying to put the lens in the bag. Lens is being injected under hydro insertion, no visco. Remember, if you are doing a hydro insertion, you need the tunnel opening to be a little more than what you would need in a visco insertion. So if my incision was 2.2, I have made it 2.8. I open up the lens, a toric lens you can see, over the iris. Then I bring it under the iris over the anterior capsule. And then I'm trying to put it in the bag. So the optics is going in the bag now. Right? But at the moment, my toric axis is not aligned to the axis that I want. Right? So I have to rotate this lens. The only one big mistake I made at this point. I'm trying to rotate it against the nature of the lens. I'm not rotating it clockwise, I'm rotating it anti-clockwise. My big stupidity, my disaster, and I had to pay the price of it. And Dr. Alka was in that OT on that day. Fortunately, we had a retina specialist in the next OT working on it. हमने कहा यार लेंस निकाल के दे दे वापस. So उसने लेंस निकाल के वापस पोजीशन पे दे दिया. Now, should I again go into the bag and do it? At that time, you're so tense. You said, यार एक बारी से पंगा हो गया, such a large rent. Let us put it over the anterior capsule and do a reverse optic capture. So we put it over the anterior capsule and did a reverse optic capture. That also works. Which means we are afraid कि यार उसका तो haptic का size छोटा है, it will not hold to the periphery. You don't need to hold it to the periphery. All you need is one optic behind the anterior capsule, one haptic in front of the anterior capsule, holds like a clamp. ठीक है ना? It's just holding like a clamp. So even if your haptic, we had one case where the haptic got broken. It didn't make a difference. We still put it in the AC over the anterior capsule and did a optic capture, and the toric IOL was still in position. So you don't need that peripheral support in an optic capture. So I'm giving you some real unique ideas. They could work for you in some very tricky situations, right? And I'll give you just the second part of the presentation, which is what happens if you have a residual nucleus. So I'm showing you with PCR with the residual nucleus. I'll make it short. So we use what is called a lens scaffold, right? So what does this, how does it work? So now suppose you were removing this matter and suddenly you see what you didn't want to see, a bright orange area behind, the rexes has run to the periphery, you have a full tear, and you are afraid that your nuclear pieces are now could drop into the vitreous, and then you would have to cut a sorry figure, send the patient to the retina specialist, vagara, vagara. Can you avoid this catastrophe? Can you still manage it? Let's see. We have designed a lens, we have called it the C7 lens. Previously it was just a contact lens, bandage contact lens, but now we have more specifications on it, which I'll talk about it later. And under hydroinsertion, you can put this lens over the iris. The size is 9.5 millimeters. It opens up, concavity up. Concavity is facing up. It opens up over the iris. You have already pushed all these nuclear pieces and debris to the side on the iris. This lens opens up, and then you guide all this nuclear debris onto the contact lens. Even these thick cortical pieces onto the contact lens. Now there is no risk of this debris falling in the vitreous. You take in a phaco probe and you just eat it up comfortably at leisure. All your pieces are in your sight, in your control. They are not falling back. Removed all these pieces. Fine. You are still under anterior chamber maintainer. Any small pieces on the sides, you can engage it with your iris, with your phaco probe, bring it to the center, take it out. Now you're only left with some cortex. With any forceps, this is a McPherson's forceps, you just hold it and pull it out. It's so simple. The ACM is maintaining the chamber at all time, and you can do your normal activity. That means you can remove it. This time, because there was no vitreous, I could just do a simple IA and remove all the cortex. Had there been a vitreous, I would have used a cutter and done a similar job. So no vitreous, and you can just comfortably put in an IOL, right? After this, I'll just move on. So now, what is important for all of us to understand? Previously, we had what was called the IOL scaffold. So if there's a PC rent, you put an IOL behind the iris or in the bag, let the pieces come on it, you remove it, right? But the IOL in the bag or behind the iris, you don't have access to the cortical material behind it. You can just put it in. The central area is clear because it's a rent. The cortex is at the periphery entrapped. You could still work. But yes, if you have an option for a neater removal of all the cortex comfortably, it could be a better idea. And the second thing is, the lens is very thin, just 120 microns and concave upwards. So there's a lot of space between the lens and the endothelium. So this is more endothelial friendly than a biconvex IOL. So we prefer this lens in this situation, and this was the first post-op day of this patient. Cornea is absolutely clear, and endothelial cell loss in this operated eye, it was 21-24, unoperated eye 24-74. So we say about a 10 to 15% endothelial cell loss, and everything is just how you want it to be. So now, for the first time, we have got it commercialized, because if you put a lens in the eye, it's a drug. It's a drug, no? If it's going into the eye. So there has to be a drug license, etc., etc. So there is one company which has started making these lenses, so you don't have to really wonder where I'm going to get these lenses from. So you just pick up a lens, open it and put it in the eye. So we have what is called a PCR kit. Thank you.
Thank you so much, Dr. Sanjay. That was truly a very, very a clear and a comprehensive talk on various situations of PCR with nucleus, with cortex. Very well showed. So one question, you were mentioning about the IOP at 18 and bottle height of 24. But on the screen, it was showing us an IOP of 30. That was a different situation? Or?
Yeah, so this was that video when we used to keep an IOP of 30 in the Centurion system.
Correct.
Now the Centurion system, you can keep an IOP of 24.
Yeah.
That's the minimum it goes. 20 tak bhi chale jata hai, haan. Yeah, 20 chale jata. So now we started using that level now.
Okay, so you found a difference between 30 and 20?
The churning up effect you expect is less. There's more stability. So we are getting an IOP from the bottle and the phaco system at 18 or 20, right? So at all times you are at 18 and 20. So that makes a wonderful combination. And there's always a concept that people, that if you are adding one IV line at 18 and one IV line at 20, so the net pressure will become 38. It does not. You add 1, 2, 3, 4, 5, all are 20, the pressure will be 20. And the moment the pressure goes over 20, your infusion will stop from all the lines. And the moment it falls to 19, the infusion will start from all the lines. But the maximum pressure will go to 20 if the bottle you have adjusted or the phaco you have adjusted, the maximum IOP it is maintaining is 20. Right?
Can I add something?
Yeah, sure. Yeah. Yeah.
Dr. Rohit? Can I want to add some sentences.
Very good question. So if you are doing a reverse optic capture, you are again in the bag. So the IOL power stays the same. When you're doing an optic capture, the IOL is in the bag. When you're doing a reverse optic capture, it comes up, but the bag collapses. So your power is more or less the same or 0.5 less. Right? Now the issue is that if you've done all that and you still have a single piece IOL and you promise that patient that lens, you won't have a back off of half there lying there. You can comfortably use the lens. Now half will only reflect as 0.3 in the overall outcome. It is about 0.3, which is insignificant, so patient doesn't feel anything.
But you can keep an armamentarium of 3-piece and iris claw ready for all patients, ideally.
So then, now this is the situation which I have told you where we can use this technique. But then some people may have more difficult situations and you may not be able to use these techniques. So my colleagues will tell you of the other situations how this is to be managed. Kiran, you had a point?
Yeah.
And then I can ask Dr. Anaga to give her way of managing when things go beyond a certain stage.
So I am going to tell you about my thought process. My thought process is that we are taught about making a rhexis which is 5.5 millimeters or 5 millimeters, and that has become our religion now. Whether you have a posterior polar cataract, whether you have a black cataract, we are bound to do that rhexis of 5 millimeters or 5.5 millimeters. But this is not the case. This should not be the case in every cataract. Dr. Rohit is behind me also. He supports me. Yeah.
And on the side.
Side. So when you have a posterior polar cataract or you have a black cataract, there is no need to do a round rhexis. You should not be fanatic about it. Do oval rhexis. Oval rhexis will help you make a very it will give you a very big area to work in, and you can make very long and deep gutters which are easy to break, and you can easily bring out the segments in the interior chamber and eat them up. And the very reason Dr. Chaudhary dropped the IOL in the vitreous was he was struggling with the leading haptic. He was trying to push it down the capsular interior capsule, but because it was round, he was unable to rotate it inside the capsule bag. Had it been an oval rexis on that side, he would have easily done the in the bag implantation. So the other point is, all the cases except the last one which he has shown all cases were of posterior polar cataract, and he was expecting a PCR and he was pre-prepared for all this. That is why he had put a Chaudhary irrigating cannula inside the interior chamber, and it is a good way of stabilizing the interior chamber, no doubt. But if you don't have that cannula, you can do the interior vitrectomy and fill the interior chamber with viscoelastic, and then do a dry aspiration with a 27 gauge cannula attached to a 1 cc syringe which has been previously flushed with a viscoelastic to increase its vacuum or suction power, so that you don't misfire while you are aspirating the lens matter from the corners of the capsular bag. And if you have oval rexis in such cases, it is very easy to aspirate from every nook and corner of the capsular bag. And when you have a round rexis, in cases of PPC, when you try to go behind the interior capsule, you usually you bounce against the vitreous, and it is a vitreous which comes into the 27 gauge cannula. So I'm not taking much of your time now.
Sir,
okay. So
Shall you come to the discussion on this
yeah,
later?
yeah.
After the talk?
So
Huh?
yeah.
Sir, do you have any suggestion about the long diameter of the oval rexis you are suggesting?
Yeah.
Should it be horizontal or vertical?
It is.
Should the long diameter be towards my main pole or
Yeah.
towards my
Long should be towards your